Hello, everyone. We'll give you just a few minutes to join. We have Dr. Parikh on the line with us today, and we'll be talking about long COVID. How does it affect asthma and asthma control? So I will start in just about 1 minute. Okay, just wanted to double check and make sure our connection is good. I see all of our participants joining, so we will go ahead and start. Hello, and thank you for joining us today. We have a few housekeeping items before we start today's program. I'm Andrea Jensen. I am the Education Specialist for Allergy and Asthma Network. All participants will be on mute for the webinar today. We will record today's webinar, and then we will post it on our website within a few days. So you can listen to it again or share the webinar with your colleagues. You can also go to our website at allergyasthmanetwork.org and scroll all the way to the bottom of the page to find our recorded webinars and any upcoming webinars. The webinar will be 1 hour, and we will have time for questions. We'll take those questions at the end of the webinar, but you can put your questions in the Q&A tab at any time. We have a staff member, Chris, who is monitoring the chat if you have questions or if you need help. We do not offer CEUs for this webinar, but we do offer a certificate of attendance. You may have noticed we are using a different platform this year. Instead of being able to download a certificate during the webinar, which is what we did in the past, you will receive an email several days after the webinar with all the resources that we will list today about long COVID and a link to download your certificate. Please be patient. You will receive a follow-up email from us. We will now begin today's webinar. There are 25 million Americans living with asthma. Any respiratory infection can cause serious complications for those with asthma. Today, we'll learn more about how long COVID impacts asthma and asthma control. Let's see if I can get the slide to go forward to advance. Just 1 moment. And we're back. Okay, little technical glitch. And what else is new? We've all been dealing with this over the last 3 years. Allergy and Asthma Network is a grassroots organization that was started over 35 years ago by a mom who knew that other mothers like her needed resources and support. Our mission is to end the needless death and suffering due to allergies, asthma, and related conditions through outreach, education, advocacy, and research. Today, it's my pleasure to introduce our speaker, Dr. Purvi Parikh. Dr. Parikh is an adult and pediatric allergist and immunologist at Allergy and Asthma Association at Murray Hill. She is currently on faculty as clinical assistant professor for both departments of medicine and pediatrics at New York University School of Medicine. She has been passionate about health policy and is on the board of directors of the Advocacy Council of the American College of Allergy, Asthma, and Immunology. She is also spokesperson for Allergy and Asthma Network. In fact, she just finished an interview right before this webinar. She frequently makes appearances as a medical expert on our behalf to NBC, Fox News, CNN, Wall Street Journal, and CBS. We are lucky to have Dr. Parikh as one of our presenters today for this webinar. Thank you for being with us today and giving us an update on long COVID and how it affects asthma and allergy and asthma control. So today we'll talk about the current state of COVID-19, How does it affect those with asthma, and what treatments are available? So if you look at our slide here, I'm just going to do the first couple of slides and then I'll turn it over to Dr. Parikh. So this is a screenshot from just a couple of days ago. This is from Johns Hopkins. You can see that once again, this is long-term and all of our stats are increasing over time. If you look at the 28-day count for deaths, you can still see that we've had about 30,000 people that have died over the last month. And this is a global numbers here. You can also look at the 28-day cases. And keep in mind that most likely this is going to be underestimated due to home testing. These are daily updates for the US. This is from Centers for Disease Control. You can see the cases, the deaths, and the hospitalizations and vaccinations. In the news, there are a lot of things in the news for any of you that are online or watching your local news. If you've had COVID-19, here's what you need to know about blood clots. Asthma can be blamed for a decrease in lung problems, but it could actually be blood clots. So another option that we're looking at is COVID-19 Omicron infection is linked to new onset diabetes. A pair of new studies concluded that compared with their never infected peers, COVID-19 Omicron survivors may be at a 60% or greater risk of new onset type 1 or type 2 diabetes, a potential precursor of heart attack and stroke. Another interesting story that's been in the news is that young people are more likely to die of heart attacks post-COVID. Since the pandemic began, heart attacks across all age groups have become more common, but especially the age groups 25 to 44, so some of our younger folks, with a 29.9% increase. Adults between 45 to 64 saw a 19.6% increase in heart attack deaths. And then the adults over 65 had a much smaller increase, 13.7% increase in heart attack deaths. Another story in the news was a woman that was 39 whose cough had been diagnosed as COVID-19 pneumonia, but it turned out that it was lung cancer. So 15% of lung cancer patients have never smoked. One doctor was quoted as saying, if you have lungs, you can get lung cancer. So those are some of the stories that have been in the news. And Dr. Parikh, I will turn it over to you now if you'd like to take over.
Oh, thank you very much. Yeah, it's been a crazy few years, especially for those with COVID and now, battling long COVID. So globally, 65 million people have long COVID. And this number is likely an underestimate because, as we mentioned, just like the actual infection numbers, because there's many likely that were under-tested or didn't know they had COVID and now are dealing with the consequences of it. Next slide. So the data is biased towards those who are hospitalized for COVID. But as we know, anyone infected can get long COVID. And now we're seeing quite a few. I'm seeing it kind of the scales tip the other way, especially after the Omicron variant came about, because so many people were infected during that surge. And we saw quite a rise in long COVID after that as well. So there's a lot less focus on non-hospitalized adult data, and even less, if you think about it, in the pediatric population. And then current treatment options for long COVID are definitely needed. And I say this on every webinar, but I think this is going to be basically the next biggest public health emergency if it isn't already, because remember, all the people, the great millions and millions who had COVID and passed away, but there were millions more, right, that had COVID and didn't, and majority of those, or at least 50 to 65% of those, are still dealing with some residual consequence. More clinical trials are needed to pinpoint the mechanisms of COVID and long COVID. And as always, we need to remember those marginalized populations and include them. In the US alone, nearly 19 million people have long COVID. And that equates to nearly 1 in 5 adults. So that's not a small number. This is according to the Center for Disease Control, National Center for Health Statistics. Older adults are less likely to have long COVID than younger adults, and nearly 3 times as many adults ages 50 to 59 currently have long COVID compared to those 80 and older. And one thought behind that is because, this is a disease of inflammation, right? It's almost like what we believe to be a hyperimmune response left over from the virus itself. So generally, elderly individuals have less robust of an immune system, which is a problem in catching infections, but luckily they're at lower risk for the inflammatory or the hyperimmune issues that come after infections. Women are more likely than men to currently have long COVID. It's about 9.4 versus 5.5%, which is interesting because being male is actually a higher risk factor for severe COVID. Nearly 9% of Hispanic adults currently have long COVID, higher than non-Hispanic, white, which is 7.5%, and Black, 6.8%, and over twice the percentage of non-Hispanic Asian adults, which is 3.7%. And we don't really know why. There's a predilection for one ethnicity over another. So states with the highest percentage of adults with long COVID were Kentucky, followed by Alabama, Tennessee, and South Dakota. And the states with the lowest percentage of adults with long COVID are Hawaii, Maryland, and Virginia. So symptoms of long COVID. So basically, the symptoms I've seen, it can be anywhere, head to toe, but it's new, returning, or ongoing health problems after a COVID infection, wide range of symptoms that can last weeks, months, or even years. They can slowly improve over time, which is good news, but the symptoms can be very, very hard to manage. And typically for the definition of long COVID, it has to be for at least 1 month, that these symptoms are lasting at least 1 month or more post-infection. Next slide. So again, it can affect multiple organs and any organ. New health conditions have come about after COVID, such as diabetes, heart conditions, blood clots, and neurological conditions can develop. Severe illness, like ICU admissions, can lead to muscle weakness, difficulty processing thoughts, and PTSD. Symptoms can be hard to explain, and unfortunately, blood tests, chest x-rays, and electrocardiograms can all appear normal. So often long COVID patients are dismissed, even though they are really suffering. So common symptoms, fatigue, and I would say this is probably the most common out of the common that I see, just very debilitating fatigue that interferes with daily life. And these symptoms get worse often after physical or mental effort. So after exerting themselves, fever, brain fog, lightheadedness, headache, sleep problems, depression or anxiety. There's a lot of new onset mental health issues in long COVID patients. And there's even more than one reported suicide in long COVID patients. And these were individuals who had no pre-existing mental health conditions that we knew of. Diarrhea or stomach pain, joint or muscle pain, rashes, and changes in menstrual cycles. So how does COVID impact asthma? Asthma control often worsens after COVID, and as a allergy asthma doctor, I see this on a daily basis. One study showed that it didn't matter if COVID symptoms were mild or moderate. I agree with that. We see it in all sorts of COVID cases. Some asthma patients had a chronic worsening of their asthma that required an increase in medications to stabilize their asthma. So again, I see that as well on a day-to-day basis, that people who may have had intermittent asthma before are now requiring a daily controller medicine after their COVID, or I've had to increase their controller medications. So the common respiratory symptoms, difficulty breathing, cough, chest pain, or tight chest, wheezing, and shortness of breath. And from, could the lung issues be something else? So we do see blood clots in the lungs that can mimic asthma symptoms. So the blood clot symptoms to watch out for are, again, a sudden onset of the difficulty breathing, an irregular heartbeat, or especially a faster heart rate than normal. So if your pulse is, over 90 or 100, then something to be concerned about. Chest pain, discomfort that's worse when you take a deep breath or cough, feeling lightheaded or faint, and coughing up blood. And I know many people, including those probably listening today, invested in pulse oximeters to have at home during the pandemic. This is also a great way to screen if your shortness of breath is your asthma or potentially a blood clot or something worse. If you notice that your oxygen levels are, much lower than usual. So the numbers that we look at is 92% or less. Definitely, if your oxygen levels are in the 80s, you need to be screened to make sure you don't have a blood clot in your lungs. So could the lung issues be something else? Again, lung cancer can mimic asthma with difficulty breathing, the fast heart rate, chest pain, feeling lightheaded or faint, and the coughing up blood too. These are all symptoms that need to be further investigated. And children and adolescents can also be impacted. So they may have trouble describing the symptoms, especially young children. It can affect school, homework, sports, and other activities. Some accommodations that can be helpful are extra time on tests, rest times, modified class schedules. Accommodations can help thinking, concentrating, or physical activities. And I have treated like a handful of young children with long COVID. Most of the people that I've treated have been teens. So I personally haven't seen anyone younger than the teenage group, but it can be quite debilitating. So these are like varsity athletes who are now having trouble walking. I've seen like new onset mental health disturbances and psychoses even. Luckily, these kids did get better, but it is quite disconcerting, especially to see in such a young population. Luckily, it's far less common in children than in adults, likely because the COVID infections seem to be less common, but it's still very real and could happen. Another argument for getting kids vaccinated and protecting them. So increasing asthma medications to achieve control. So again, this is similar to our stepwise asthma approach, that we use even in asthma outside of COVID. But, of course, we'll first look at how frequent the symptoms are, how much they disrupt the day-to-day activity, how much rescue inhaler or quick relief inhaler is needed if there's nighttime symptoms. And similarly to how, we come up with the appropriate regimen for our asthma patients, long before the pandemic, it's the same principles apply here. So, I know many of you on this call are very attuned to knowing when your asthma is off, the things to look for, from peak flow measurements to nighttime symptoms to albuterol use. So all of the same things we look at. And then same thing for these children 5 years and younger as well. In children 6 to 11, again, the asthma options are similar as the under 5 group, but there are some more increased options. Again, we try to treat any modifiable risk factors and comorbidities, make sure there's no other confounding issues like allergies triggering their asthma, or especially as we're going into the spring allergy season. And of course, in this group is a little older, so it's easier to confirm that asthma diagnosis. Under 5, it's harder to do like a pulmonary function test, but some children between the age 6 to 11, depending on the child, are able to perform those spirometry measurements or peak flow. So it's we have a little bit more objective data here too, in assessing and controlling their asthma. And then 12 and older, our adolescents and teenagers, again, this we can even personalize it further, right? We could do a lot of those objective measurements like exhaled nitric oxide and peak flows and spirometry, and we can really get a better clinical history too. In the under 5 and even 6 to 11 age group, sometimes we're reliant on the caregiver or parent for the history, as a child can't always express how they're feeling or what they're feeling and how frequently. But in the adolescent and teenage age group, it's easier to monitor those symptoms, especially the nocturnal awakenings or symptoms on exercise. This group is more likely, right, to be participating in sports and other after school activities that might be impacted by their asthma. But again, the same stepwise approach is used in treatments in terms of controller medications, from inhalers to dual inhalers to even biologics if necessary. So what treatments are available? So medications used to treat COVID-19. So pain relievers and over-the-counter drugs may be enough, but always check with your doctor to see if other medicines might be needed, especially if you're in a high-risk group. And asthma, COPD are high-risk groups, elderly individuals, immunocompromised are high-risk groups. And the antiviral drugs such as Paxlovid or Molnupiravir might be helpful. But the important thing is that always consult your physician, because we may opt to put you on a medication even if you think you may not need it, to prevent the severity of the disease. So antiviral drugs that we use, in both acute and long COVID, we've found that research are testing antiviral drugs, Favipiravir and Maripiprazib. I can never pronounce that. But studies have found, excuse me, that the combination of lopinavir and ritonavir isn't effective. Anti-inflammatory therapy is frequently used to prevent dysfunction of severe organs and lung injury from infection-associated inflammation. Dexamethasone is one type of anti-inflammatory drug. It's a steroid that we are studying to prevent organ dysfunction and lung injury. And it really, in COVID, studies showed that it reduced the risk of death by 30% for people on ventilators and 20% for people who need supplemental oxygen. And then there's immune-based therapies, convalescent plasma, stem cells, monoclonal antibodies. And these are treatments that we're not using as much now for acute COVID, but they're all being studied for long COVID. So unfortunately, a lot of our monoclonal antibodies that we have no longer are efficacious against the newer subvariants of Omicron for actively infected individuals. And the same goes for convalescent plasma. Stem cells really haven't been tested for acute COVID, but I know some patients who are experimentally receiving these therapies for long COVID. Luckily, the two antivirals, Paxlovid and Molnupiravir, which is the Merck one, are both still efficacious in reducing severity and symptoms from acute COVID. And now those antivirals are also being studied in long COVID. I know Stanford is looking at Paxlovid in long COVID. So approved versus emergency use authorization. So fully approved treatments by the FDA are the antiviral drug remdesivir, which we usually use in the inpatient side in both adult and certain pediatric patients. It's given IV, usually for those patients who are admitted to the hospital, have low oxygen levels, are very sick, or on a ventilator. And then certain immune modulators that help, with COVID, the infection itself is bad, but all the inflammation that the infection brings with it is really what causes a lot of the destruction in the acute phase as well as in long COVID. So a lot of immune modulators are used to kind of dampen that hyperimmune response that can be so deadly. Olumiant is one, Actemra, these are all for hospitalized patients. Emergency use authorization has been granted for the monoclonal antibodies, as well as the 2 oral antiviral pills I had mentioned earlier for the outpatient setting. So what is pulmonary rehab and why is it so important? So this is a treatment program of educational classes that are supervised by pulmonologists, respiratory therapists, occupational therapists, physical therapists, and social workers and dietitians. And it's extremely important in the recovery. We always focus so much on medications, but the rehabilitation side of it is just as important. So certain breathing techniques such as yoga can really help with a lot of the breathing symptoms post COVID, and can even help improve lung function in some cases. Counseling is extremely important for emotional problems. The whole pandemic is a very, very traumatic experience for everybody collectively, but some more than others, especially if you were extremely ill, if you were intubated or in the hospital. Those are all very traumatic experiences. If you know a loved one who was affected by COVID or passed away from COVID, counseling is so important and very, very underrated, especially as we are seeing a surge of mental health illness after COVID, both by people who are infected and not. Energy level, this is why pulmonary rehab is better too. Often, this infection wipes you out. People are fatigued. The rehab can slowly, gradually help you build back your energy level again. And education is, you can learn about different respiratory medications, oxygen therapies, nutrition. Nutrition is crucial to recovery. And of course, exercise as well has numerous benefits in recovery. So who qualifies for pulmonary rehab? So anyone who has an underlying lung condition and then has developed COVID, or even developed a new lung condition because of their COVID. So anyone with asthma, new onset or old, bronchiectasis, chronic bronchitis, COPD, cystic fibrosis, emphysema, lung transplant. Remember, a lot of people, especially early on before the vaccine, required lung transplants. Even very healthy young individuals needed single or double lung transplants because the COVID virus destroyed their lungs. Neuromuscular disease, occupational or environmental lung disease, post-surgery, pulmonary fibrosis, pulmonary hypertension, respiratory failure, sarcoidosis. So again, it can help a whole host of lung conditions and help you get back, back as close to normal as possible. So what are some devices that are used? So the Aerobica, this is a great device. It helps really clear mucus from the lungs, especially in people who have certain conditions or a certain anatomy where they can't clear that mucus. So in COPD patients, cystic fibrosis patients, but it can even help some asthmatics as well, who have severe asthma or have difficulty bringing that mucus up. And then the incentive spirometer. So this trains you to breathe deeply and slowly. And by doing that, you inflate all areas of your lungs. And we give it to pretty much every patient in the hospital, because even if you're healthy and well before you come into the hospital, just being in the hospital deconditions you, your whole body, including your lungs. Laying in that hospital bed also deconditions you, and it causes lung to collapse. So this is a very great and easy to use thing where you can carry anywhere with you. And same with the Aerobica. Next slide. At-home oxygen is important. There's oxygen concentrators for the home. This is usually prescribed by your doctor because not necessarily everyone needs one, but it's delivered to your home, set up by a home health agency. A bubbler bottle can be added. It kind of works like a humidifier to keep the airways nice and moist. And then smaller size tanks for travel also are there. So not everyone necessarily needs one or will qualify for one, but if you're somebody who needs it, it's a great resource. So the cannula versus oxygen mask, it's important, based on the patient, you can tailor what's best for you. Some people are more comfortable with the nasal cannula, some need the oxygen mask. So it all depends on the individual patient. And, your pulmonologist along with the respiratory therapist will work with you to get the correct device for you. And of course, this is important if you do have an oxygen tank at home, no oxygen safety, don't keep it in an area where might be fire, as these are highly combustible items, no open flames or smoking around it. But, granted, if you have a lung condition, you probably should not be smoking regardless, but just these safety items are key to avoid any tragic outcomes. And learn to pace yourself. There is this need or want in most people, which I totally get, after, coming off of a COVID infection, people are just dying to get back to how things were. And they just want to get back to their routine activity, their job, and nobody likes to be really a patient, but if you use all your quote unquote spoons at once, then the next day you'll be completely wiped out. That's the whole idea behind the spoon theory. So you'll pay for it tomorrow if you overexert yourself. And so the key here in the post-COVID recovery is slow and steady wins the race. And I know nobody likes to hear that, but I've been working with patients who are like marathon runners and pro athletes and Navy SEALs. And now I have to tell them that, okay, you're only allowed to, the first week take 5 or 10 minute walks a day. And to them, that's mind blowing, because they're just used to performing at such a high level. But then they pay the price if they push themselves too hard. And then the long COVID, it sets back the recovery. So movement is very good. Very much a fan of it, but you have to start slow. So maybe low impact things first, get that rehabilitation going before going back to your, more exertional or more cardio involved activities. So how many spoons or energy does each activity take? So, some of these long COVID patients will tell me that they can't even get out of bed, or get dressed or even watch TV because the brain fog and fatigue is so severe. So you really have to tailor this to your individual situation. Some people are lucky they get better from COVID and within a week or two, they're back to their baseline activity. So again, just plan ahead while you're trying to get better and don't push yourself. If remember, you're recovering from a very severe and unprecedented type of virus that our immune systems have not been used to before. So if it does take some time, to do these activities, if you're stuck at spoon 1 for a week or 2 after infection, that's okay. You'll get there, and then slowly you can build your way up. COVID qualifies as a disability. So in July 2021, long COVID, also known as post-COVID conditions, was added as a recognized condition that could result in a disability under the Americans with Disabilities Act. And Section 504 of the Rehabilitation Act of 1973. So it's because it substantially does limit one or more major life activities. And we can go to the next slide to see some examples of that. So, a person with long COVID who has lung damage that causes shortness of breath and fatigue is substantially limited in their respiratory function, among other major life activities. And then the person who has the intestinal pain, vomiting, nausea that often lingers for months also is impacted. And the person, again, with the neurological issues like memory lapses or brain fog substantially is limited in brain function, concentrating, and or thinking. So monitor your condition, the trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake. And if you're having any pale blue colored skin, gray skin, lips or nail beds, depending on the skin tone, this could be an emergency symptom, So this could be a sign that you're either developing acute COVID or there is something dangerous going on and you should seek medical attention. Again, the COVID-19 treatments, they are very helpful. The monoclonal antibodies, again, like as I mentioned, we're not using as much, but the antiviral pills, they still are working with the newer subvariants. So here are some tips to kind of help your mind, body, and emotions. Manage information, limit social media. I know I've had to do this myself because it's just too much, there's a bombardment of information coming from all angles. Practice compassion, remind yourself that this is temporary. The good news is most people do get better, even though it may feel hopeless or there's no end in sight. Try to reduce boredom by trying something new, get outside, focus your attention on something else. Recognize the feelings of loss. It's okay to feel that grief. And again, access a counselor or mental health specialist if needed, and eat healthy and sleep. People always ask, what can I do for my immune system? But it's very simple. As long as you're getting enough sleep, drinking enough fluids, and eating good, healthy fruits, vegetables, non-junk food, you'll do well, And again, the breathing techniques as well. So there's some great resources for people and their families and caregivers for long COVID. Again, there's federally funded COVID support and services for the family, caregivers, for childcare. You know, if you're so exhausted you can't take care of yourself, let alone your children, there is, you know, support for that. Community service, education support. There's food and nutrition support, healthcare coverage and access, housing, income, financial assistance. You know, we did say it qualifies as a disability, job assistance. So you should know your rights. You know, in the U.S. Department of Labor, you can contact their Office of Disability if you're struggling with any of these things, and there are resources for you. And then you also qualify for FMLA, which is Family and Medical Leave. And this applies to public agencies, public and private elementary and secondary schools, companies with 50 or more employees. And then it can be used for birth and care of a newborn child, placement with the employee of a child, for adoption or foster care, care for an immediate family member. So you can get FMLA even if you're not the one ill, but you're taking care of someone that's ill. Medical leave if employee is unable to work because of a serious health condition. So there are a lot of options out there. So you shouldn't feel lost or like there isn't something that can be done. And again, employees are eligible if they have worked for their employer for at least 12 months or at least 1,250 hours over the past 12 months and work at a location where the company employs 50 or more employees within 75 miles. Also, military family leave can also afford FMLA protection specific to the need of military families. So planning for long COVID, community support is very important. Similar to any chronic condition, this is considered a chronic condition. So find people with the same condition. The sense of community gives patients a place to discuss topics related to long COVID and peer support. Now there's a lot of virtual and in-person options, because I know if you're not feeling well, it's not easy to leave the house and go to places, but there are virtual options. And then also you have camaraderie and support. And also planning, you know, if again, we don't know how long COVID will last for any given individual. So there should be a plan in place, especially if it's going to be a lengthy illness. So a financial plan, if needed, seek out food assistance, local programs offering transportation, housing stipends, utility bills. So start looking sooner rather than later. These resources exist, but you do have to plan ahead and apply for a lot of these things. And then there's all different accommodations that are available for both children and adults, work from home, flexibility in terms of work or school hours, but you know, support is needed from both employers and HR departments. And it is a real medical condition. There are hundreds of centers across the US that have clinicians from different specialties collaborating to treat various long COVID symptoms. So hope and help are available, and don't let anybody kind of tell you otherwise. And I've met many patients who felt frustrated and gaslighted by not being taken seriously, but it is very much real, and it's recognized by by every major medical center in our country and globally. So with that, we have about 20 minutes left, so I think we can get through quite a few questions. So
yes, thank you, Dr. Parikh. Lots of great information, and you have such great insight because this has evolved over the years, and I know that they're learning new things all the time. So we'll see what questions we have here in the chat. So someone asks, is a fever uncommonly high with the flu?
No, so actually fever is very common with the flu, and that's one of the ways that we can tell the flu apart from common cold and other viruses. So typically, you know, in the medical world, your temperature has to be over 100.4 to count as a fever, but in the flu and even in COVID and with other viruses, but especially flu, fevers can get even as high as 101, 102. In kids, I've even seen close to 103, 104, you know, so those high fevers are very, very common with the flu.
Okay. Okay. And then another question we have is, can a person with asthma symptoms feeling like they have to use their inhaler more than often, but they have a normal PFT? Does that happen?
Yes, that can happen. Traditionally, the definition of asthma is, what we call airflow obstruction on the PFT that reverses with the rescue inhaler, but not everybody shows up on the PFT because one, the PFT itself is a difficult test to perform. Some people's asthma is very situational. So it's triggered by specific triggers or allergens or exercise, or it's occupational. So their PFT may look normal in the office, but when they're around their trigger, it would be very different. So the gold standard test for asthma actually is something called a methacholine challenge that we don't perform as regularly anymore, but absolutely the PFT is just a test, right? So not every test is perfect, so it can miss some asthmatics. So that's why we have to look at the whole picture. That's why your doctor will take your history, will examine you, and do the PFT. We can't just rely on one.
Right, right. And the more detail that you can provide to your doctor as far as symptoms and timeline and things like that will help as well. So let's see, another question we have, can long COVID be misdiagnosed, for example, for mycoplasma pneumonia or other types of respiratory illnesses?
Yeah, absolutely. There's no test, unfortunately, that exists for long COVID. So it's still very much a clinical diagnosis. So long COVID can definitely be misdiagnosed as something else, and other things can be misdiagnosed as long COVID. So it can go both ways. So some people might assume they have long COVID, but it could be something else. That's why it's important to rule other things out and not just assume it's long COVID, or the other way around, where could be labeled something else and it's long COVID. And hopefully one day as we do more research, we'll have more accurate testing. So that way we can really discern what's going on.
Great, great. Thank you. And you're right, it changes every day that I turn on the news. There's something new about long COVID. They're doing lots of research and really trying to understand. Our next question says, how is Paxlovid COVID rebound related to asthma? I had a terrible rebound a few days after my Paxlovid ended.
Yeah, that's a great question. So the Paxlovid rebound, luckily, even though it was all over the news, it actually is not as common as people think it is. So I've seen anywhere from it reported to be around 2 to 3%, up to the highest I've seen is 10 to 15%. So that means the majority of individuals who take Paxlovid luckily don't have that rebound. And I can, confirm that with my own clinical experience. Like I've prescribed a lot of Paxlovid and there have been rebound cases, but luckily majority of people don't have that, that scenario. But regarding the asthma, sometimes it can cause, it all depends how well your asthma is controlled, but sometimes it can cause a flare up of the asthma. If let's say you're improving and then you have that rebound effect and then the virus kind of comes back with the symptoms. So I know the FDA has asked Pfizer to kind of look deeper into this rebound scenario and actually restudy the drug, to see if there are certain groups where the dosing actually has to be changed so the rebound doesn't happen. So one thought is that, is it all rebound? We don't know. Or is it just that some people need to be on the drug longer? So maybe asthmatics will need to be on it for 10 days instead of 5. Maybe elderly people will need, or people with other pre-existing conditions will need to be on it for longer. So that's why the FDA is really pushing Pfizer to do more studies and really look at who rebounds and why. And does the dosing have to be changed? Because, with any antibiotic, for different reasons, we give different doses for different periods of time.
Interesting. I love that. And those of us with asthma, me included, we always are those problem children that when we get sick, we get a lot sicker than anyone else when it's a respiratory illness. So that makes sense that they're looking into that to see if there needs to be a longer treatment or something for those with asthma.
Right.
Great, great. Okay, let's see. Another question says, what treatments are being considered for children and adolescents who have long-term coronavirus symptoms? I know we did talk about that a little bit.
Right. That's a great question. So with everything in children, people are afraid to study kids first because they're kids, so unfortunately children always have to wait until things are first studied in adults. cleared in adults as safe, and then studying it in children is a bit complicated because you have to study it separately in each age group, because as you know, a teenager is very different, their body physiologically, than a toddler or even an infant. So currently, to my knowledge, I don't actually think much is being studied with long COVID in children. Right now, most of the focus is on adults. I hope that will change, but as for now, there unfortunately isn't much going on.
Okay, great, thank you. And that can change quickly, as we know. Every day when we turn on the news, there's something new. So fingers crossed that this will trickle down to all the little the adolescents and children. So another question says, I have seen research showing that exercise may be counteractive to those with long COVID. Would you still recommend pulmonary rehab?
Yeah, that's a great question. So exercise can actually make long COVID worse in the short term, especially heavy exercise. So that's why I was saying earlier, slow and steady wins the race. So there is like a phenomenon where, any type of exercise, even if you're not sick, temporarily like increases stress and inflammation in your body, right? So if you're doing that when you're already in a inflamed state or fatigued state, it can make you feel worse. But pulmonary rehab is a little bit different in that it's a different type of exercise, and it's actually vital in this scenario because we're actually trying to, one, improve lung function, get those lungs nice and open again that may have collapsed from being immobile or sitting in the hospital or on your couch, recovering from COVID, and also kind of bring up any mucus or inflammation that might be trapped in the lungs. So pulmonary rehab helps with both of those things. So it's a little bit different than the exercise that is counterproductive in long COVID is like going out and, running 5 miles or, doing something very heavy cardiovascularly, or a HIIT class or an aerobics class, something that's really hard on the body. But something like pulmonary rehab is actually very necessary, and if anything will help improve the healing and reduce that inflammation in the lungs.
Perfect. And that's sort of what you mentioned early on when you have these marathon runners that say, what do you mean I can't get back to my regular training schedule? No,
right.
You have to start out slow again. Sorry to tell you this, but
yes, exactly.
Yeah. Okay. Another question says, what is the youngest age that aerobica can be used on?
Oh, that's a good question. So it can be used as young as one is able to use it. So I know that there are some cystic fibrosis patients that use it even down to age 5 or 6. Obviously, like infants, it can be a little bit difficult for them to use that device, but I can get back to you with the exact like age indications. Most of these pulmonary rehab devices are based on the individual's use. And so like two children may be very the same in age, but very different in what they can do. And same thing goes for pulmonary function tests. So there are some like 7 or 8-year-olds that can perform the spirometry or pulmonary function test, and some that cannot, But regarding the exact age for aerobic, I don't know off the top of my head, but we can look that up and get back to you.
Okay. And that makes sense. I mean, just like you can have a kindergartner that can whip out their inhaler and have perfect technique. Then you have a high schooler, not so much. So yeah, it does depend on the person. So let's see. Another question says, should people with long COVID be vaccinated? Will there be a yearly vaccine like a flu, or should we vaccinate every time a new vaccine comes out? What will be the recommendation?
Yeah, so I think the short answer is I know all of the, national health agencies are putting their minds together on what really the vaccination schedule will be for COVID. Up until now, we kept, doing booster after booster, and then now the bivalent booster. But now there is, talk of it moving to more of like a yearly vaccine similar to the flu shot. There might be certain, of course, exceptions where people might need it more sooner or more frequently. Same way, like with the flu, there's a special flu shot for seniors, and then there's other vaccines for different age groups. So that vaccine schedule is basically coming out, and it's not necessarily anytime a new vaccine comes out unless there's a need for it. So this bivalent booster was very important for everybody to get because it's the most updated booster, right? That's with our current variants and subvariants. But not everybody needed all of the previous boosters. Some of those were based on age groups and pre-existing conditions.
Great, thank you. Another question says, a child or a teen who is diagnosed with long COVID, would they qualify for a 504 on their education plan? If so, would this be considered short or a long-term accommodation? And looking at that, is long COVID, is that considered long-term or short-term?
Yeah, that's a great question. So I think it definitely would qualify for a 504 accommodation. And I would classify it as long-term because, again, we don't know how long it will last. So worst case scenario, you can get a long-term accommodation. And then if similarly, like what we do with food allergy, if a child outgrows the allergy or the doctor clears them of it, the allergy or asthma, that 504 can always be changed, year to year. But I would say that it classifies as a long-term accommodation, at least initially.
Okay, great. Another question says, if you've been sick and you can't get care, you have a severe diagnosis with symptoms, what resources do we have to move forward for a workup with a diagnosis, et cetera?
Okay, so sorry, go ahead.
No, go ahead.
No, I was gonna ask, like, what in terms of resources, if they meant more medical or financial.
And what I'm wondering about this too, it says someone who can't get care. So, and one thing they could be referring to, and we get this question quite a bit at Allergy and Asthma Network, pretty much every day. Some people can't afford a doctor or don't have insurance. So there are clinics, federally funded clinics. If you can do a search, we have no connection with this, but Needy Meds is a great website. I have actually used frequently, even for family members that live out of state and have moved and they don't know what resources are near them. You can look up dental clinics, vision clinics, mental health clinics, and medical care clinics. Just put in your zip code and it will pull up clinics in your area that are low income. They're based on a sliding scale. So if you don't have insurance, you can't afford to be seen, this is an option, and you pay what you can based on income. And generally they also have pharmacies inside the clinic, and so it's also low cost prescriptions as well. So hopefully that answered that question. Did you have anything you wanted to add?
Yeah, I agree completely. I was going to mention those federally insured, the federal clinics, but also I would add, now there's a plethora of clinical trials that are ongoing for long COVID. So you can always enroll in a clinical trial and it's completely free. And often they'll also compensate you for your time and provide transportation. So that's another option too. And then you have the access to the treatment as well.
That is brilliant information. And I wish I had this off the tip of my tongue or top of my head. I think it's clinicaltrials.gov might be the website, but
yes, that's correct.
Perfect. So yeah, great opportunity. I'm glad you mentioned that. Someone asked, are there any other long haulers who have developed issues with ears and equilibrium that bring on vertigo and dizziness? I've had 3 ear infections in 3 months post-COVID, but none in my youth. Oh, Dr. Parikh, are you there? Did we lose you? Okay, we might have momentarily lost Dr. Parikh. Let's go on and see if there's any other questions here that we can go over. Let me just scroll through these and see if there's anything else. If Dr. Parikh doesn't join us in a few minutes, one thing I wanted to mention, and she'll probably is just reconnecting, so let's just give her a minute, but you may have seen in the news that there potentially is going to be a shortage of albuterol, and many of you have probably heard that. One thing to keep in mind is that this is the liquid albuterol, so something that you're using with your nebulizer, with your compressor unit. There are 3 manufacturing facilities are going to be shut down here in the U.S. So that has a little bit of been concern for some people. So Keep in mind there are other options out there. Inhalers should still be available. And really some of the things that Dr. Parikh showed on the chart from Gina about treatment and really preventing a lot of that inflammation from happening in the first place can be really important, such as taking your daily controller inhaler. That can really help. And Chris, that's monitoring our chat, I think that she has a link to that, and she can put that in the chat for anyone that's interested in our information about any of the shortages with long COVID. Dr. Parikh, are you back yet? It doesn't look like you. Gotta love technology, especially when things short out like that. The other thing that I did want to mention, and Chris, if you could also put this in the chat, there is a new sort of a study that's going to be coming up, and it's from the FDA, and they are looking for patients to give their input about what it's like to have long COVID. They're going to be developing some new medications for that. So they have done similar groups like this. There was one last year and the year before. There was one for allergies and there was one for asthma. I was lucky enough to be able to participate in those. And I think really giving researchers and some of the drug developers feedback on that is really important. And hopefully Chris can put that in the chat. That is going to be on April 25th. You can register for that with the FDA and give a little bit of input as to what it's like to be living with long COVID and some of the things that will be that could be helpful for you. So it looks like Dr. Parikh isn't able to rejoin us. Once again, technology, we've all dealt with this over the last 3 years. When technology works, it's great. When it doesn't, oh, what do? You go on to the next project. So we would like you to join us for our next webinar. This is going to be on Wednesday, March 22nd at 4 p.m. Eastern Time. This is on disparities in allergy and asthma care, leveling the playing field. You should be able to register for that on our website. You can easily go to allergyasthmanetwork.com, scroll down to where it says webinars. It has a little light yellow box around it. You can easily access it through that. So thank you again for joining us about long COVID. Once again, look for an email that will come out within a few days that will have links to different resources that we've shared today. That will also have the link so that you can download your certificate for attendance today. So thank you for joining us. This is Andrea Jensen for the staff at Allergy and Asthma Network. Join us as we work every day to help people breathe better together.